Hi, everyone, and welcome to today's webinar entitled Focus on Behavioral Health Cost Allocation, Getting the Basics Right. My name is Chloe Santos, and I am the program coordinator here at Capital Link, and I'd like to thank you all for joining us today. This is the first webinar of series offered through the Delta Center for a Thriving Safety Net. The full series, entitled Understanding Your Costs in an Evolving Payment Environment, has been developed by Capital Link with input from JSI, and we'd like to thank JSI, the Robert Wood Johnson Foundation, and the Delta Center for supporting this effort. Today's webinar will also be recorded and posted on our website, along with the PowerPoint and on the Delta Center's site, as well as subsequent webinars in this series. Presentation will last about 15 minutes with 10 minutes for questions at the end, but feel free to ask questions through the presentation in the chat box located in your GoToWebinar on the right-hand side, where you also will find a handout section of today's slides. Today's speakers are David Kleiber, who is our project consultant at Capital Link, and Bob Urquhart, consultant and retired FQHC CFO. With that said, I'll turn it over to Dave to get started today.
Thanks, Chloe. I'll start out by echoing your comments there in appreciation of the JSI and Robert Wood Johnson Foundation for sponsoring this set of webinars. So as you can see, what we're going to talk about throughout all four of these sessions, and you can flip the slide if you want, Chloe. We have 40 slides here. We're going to have to keep this moving. So appreciate your attention. And if you do have an option to download this and look at it in your leisure. So if we move through things fairly quickly, you can always go back or use your chat and question capabilities there and let us know if either we're moving too fast or you have questions. We can certainly deal with those. So there are going to be 4 sessions in this whole presentation series. The first one we're doing today is just getting the basics right, and then the second one, which my colleague Bob Urquhart, who's the CFO for, I was going to say a zillion years, Bob, but that wouldn't exactly, it's not quite a zillion, right? We'll take care of preparing the internal statements and systems for gathering cost data. And then we'll flip over to kind of moving this towards more of the value-based payment and the changes that those systems will bring to your accounting systems, to your payment systems, reimbursements, and how you would cost differently under those scenarios. And the last one will be largely how you're going to use that information through a couple scenarios that we'll lay out. It'll use that information for negotiating with payers, which is, of course, the big piece of this whole thing. Okay, next slide, please. All right, so the evolving payment environment, what exactly does that mean? It means different things to different people, but in general, we're talking about that the system's moving towards an outcome-based, based system as opposed to a volume-based, visit-based system, and it means that those outcomes are produced at lower cost, which of course is, or perhaps just stop rising, but everyone who's in control of the purse strings would love to see those costs reduce. That's a tall order, as we all know. But it requires that 3 things happen, and this is true whether across it's medical or behavioral health. And we have to be able to, we have to be able to define and measure those outcomes. So we'll talk about that in various parts of this 4-part series. Today, we're going to talk more about the costs and the methodologies for figuring out the costs. And that's the second piece here. We have to know how to accurately calculate that for whatever outcomes we are attempting to produce and be paid for. And then, of course, the key to this whole thing is that whatever your costs are, you need to get reimbursed sufficiently to actually cover them. Next slide. All right, so this is right off the National Council website. And I think it says a lot to this whole situation. There is a 3-part solution. There was 3 parts to the steps we need to get there, and there's a 3-part solution. So what the council chooses to put out here is interesting. We need to close the gap between those needing behavioral health care and those receiving it, which means our access has to be opened up. There's an awful lot of behavioral and medical care services out there, even in the safety net. doing a variety of services, but still, I think most people would acknowledge that not everyone who needs behavioral health care, mental health care is receiving it. This is also, I guess, the key to that, or perhaps one of the ways to get to that goal, is to better integrate our behavioral and medical care. So, integrated medical care, integrated behavioral health within the medical care environment is not only a good idea and kind of a general mantra we've been hearing over the last couple of years, but as far as this presentation goes, the four of them, you're going to hear us kind of leaning towards that as a possible goal for us in order to get to create a future in which your outcomes that you had a lot of impact in creating, you actually get paid for. So I think what we'll say over and over again during this presentation is that one of the challenges in the behavioral health care, as you all know, and you represent, by the way, I know you represent that a lot of different avenues, if you will, methodologies, treatment systems within behavioral health. It's not a homogenous one-size-fits-all industry. But all of you have come up with solutions for creating outcomes that you would like to get paid for, but not all those outcomes are demonstrable to the extent that a payer would be able to say, okay, here you get to share in a shared savings program, for instance. And then the third part here to move on is expand the use of evidence-based practices. So that's true everywhere, and in medical and behavioral health care. And one of the things that we're going to talk about in this set of four presentations is the fact that one of the avenues in for behavioral health care is in the integrated treatment of chronic conditions. So a chronic medical condition often comes with, as you know, often comes with a behavioral health component. And with that, that's your avenue in to be able to have that impact on that patient. And the key then is to make sure that you can get paid for the improvement in that patient's outcomes that are generated by your activities. Next slide, please. Well, that all sounds good. I mean, I think everyone realizes that's where we're going, and you're probably all nodding your head like we've heard this a zillion times, and you have. The industry talks that talk. But it's just not easy quite getting there. I picked this picture for a good reason. That is, you'll notice that this looks like every overshot of every interchange in the country, but you'll notice that there are no on ramps or off ramps here connecting these three. So here we are at the we're the junction of three different major highways, but actually all they do is pass each other. So in a way that kind of symbolizes where we are in many parts of the healthcare world, whether that's primary medical care, behavioral health care, and then substance misuse. Perhaps those are the three roads we're looking at here. But anyway, we have to build those on-ramps and off-ramps. We have to connect this so that the individual who presents to us with a set of I'll call them illnesses, call them conditions, we have all the tools we need at our disposal to be able to help that person. Next slide, please. Okay. Well, our angle on this whole thing is to talk about introducing cost accounting methodologies to this industry. And it's interesting. I don't know, some of you may have heard of Michael Porter before from Harvard University. He's obviously a big name in academic circles, a big name in many kinds of in business schools all over the planet. I can attest to having read Michael Porter back a million years ago when I was in business school. But he's a bright light looking in at the medical care community and realizes that we have a long way to go in the healthcare world. And that's healthcare writ large. And in order to get this industry to where other industries have already gotten in introducing cost accounting methodologies. So you're not really behind because we're all behind. So if any of this is new or different, it's because it hasn't been necessarily fleshed out in the way we're going to do it. Now, I'm going to move on from this slide, but Chloe, you can move on. But I do want to say that this particular presentation, this first one, we're going to talk about some of the older ways that this has been done and the importance of doing it, from that top level down. And so that's the key here. You're going to, we're not going to change maybe the way you think about how costs are allocated and how costs are divided amongst all of your programs. And so that when you come down to a number, which is easy enough to produce, and Bob will be the first to attest that your numbers are your numbers. You'll hear that say that a million times, but how you package those numbers, how you allocate them into different buckets is what allows you the powerful tool to approach your funders to say, we need more in this particular program in order to get what you, funder, want. Next slide, please. So Capital Inc. It took on a project about a year or two ago in which we updated a publication we have, which was available on our website. So you can go to that link. This particular one is aimed at the federally qualified health center industry. So it's primarily primary care, but of course we all know integrated primary care includes behavioral health. So all the aspects of it still apply. So it talks about costing per visit. That's been the mantra forever, right? This is where, to a large extent, we're still visit-based reimbursement. And while everyone talks about how that's changing, for many of you, that hasn't changed dramatically. Now, at least on your client services piece, it hasn't changed dramatically. I know a lot of you are also grant funded and program income funded. And from that, it's less visit-based than grant-based, and we'll talk about that as well. But this publication is useful if you want to really get into the nuts and bolts. It's like I said, it's geared a little bit, and we'll talk about how some terminology changes going forward. But this on a cost per visit basis, this is a great publication to have. It's free to download at that website. Next slide, please. Okay, so as we move forward, we're going to be talking about 4 different components of costs: provider costs, direct support costs, enabling costs, which is a new word probably for a lot of you who are not involved necessarily in the primary care medical world, and overhead costs. So don't worry that you've got to learn some new vocabulary. All we're really doing here is breaking it down, these 4 buckets, so that we can analyze these costs, put them into recognizable areas that differentiate themselves enough so that when you're dealing with program income or your basic outpatient visit income revenue and programs, or chronic care of a patient, which we'll talk about in the next several presentations to come, it'll be clear where you want those costs to go and where they belong. So we're going to walk through a lot of slides on the provider side, which will apply across this entity, and it'll apply if you're on a managed care basis as well. But and then we'll talk about the direct support costs, which are individuals who may or may not be billable, generally are not billable. We're going to define providers as those whose services can be billed and are licensed to be for your practice to be billed. The direct support costs, those who help out in helping those providers achieve the outcomes you're after. Enabling costs, which it will define as all those, and we'll have a list later on, so don't worry about having to figure this out or write anything down. But it's your transportation costs, it's your enabling costs, your case management, all those things, care coordination, health education, all those aspects of your practice, which, especially in behavioral health care, are absolutely essential to getting the outcomes you are looking for from your patients, but may not be directly reimbursable. And then, of course, the big one, overhead. We've seen that number. Large factors being applied to overhead, which it really is fine at the 30,000-foot level, but not so good when you're trying to drill down to create a number that you can take to your payer and say, this is what it costs when the next patient walks in my door with this set of circumstances or this set of conditions that you were trying to help them with. Okay, next slide, please. Okay, so you may have noticed a little bit of difference between that approach and what you might be used to when you talk about healthcare accounting, right? And most of the time we've put everything into either direct buckets or indirect buckets, and that tends to be by department, and that's not a bad way. We're not. Don't take away from this that we're somehow dissing what you probably have known forever. It's that the world's getting a little more complicated, and certainly payers are getting more sophisticated, and we all know that you need a better way to get more reimbursement. So you've been as an industry, behavioral health has been banging on the door forever, trying to get more reimbursement, better reimbursement rates for the services you provide. And we all know that it's not particularly been effective. In some cases it has. And part of that is because we need to be able to provide payers with more evidence that, in fact, this is the cost of what it costs us to produce the outcomes you guys are after. And that's where the silos come in, right? So we've been siloing medical care and behavioral health care and substance abuse. I was the board chair and been on a board, treasurer, various positions of a behavioral health organization for 10 plus years. And, it wasn't until last year that we got involved at all in primary care. We talked every now and then to the local federally qualified health center. We certainly hoped that our patients all had adequate primary health care, but we had no active role in that. And we all know the statistics about how those folks with seriously mentally ill tend to have lifespans that are up to 25 years shorter than the average individual, which of course is a glaring unfair situation in our society, and it's plagued us and persisted for too long. So one of the ways we got to get past that is the integration of primary care and medical care, and interweaving with that how we deal with the social determinants of health. Right, that's a fairly new, but I'm sure you've heard it a million times now, concept. And so in healthcare as a whole, is that person approaching us has many diverse conditions and has been subjected to various situations in their lives, which all impact their health. And we can't just have them come in and then go, oh, you belong in silo number 2 there because your primary situation is X or Y or Z. We need to pull from all 4 of those silos, right? Or however many we have, how many toolkits we can put together to make sure that we have everything needed to get that patient stabilized, get them moving forward. So we're going to take a little bit of a different tact here over this whole 4-course series, and try to drill down to come up with a more patient and visit, if you will, but mostly patient-centric way of looking at costs. Again, to arm you when you go in and negotiate with payers. Okay, next slide, please, Chloe. Okay, so the next couple of series of slides is just going to talk about that first one that first of the 4 elements, provider costs. And Bob, I'm going to, I know I've been talking like a madman, which you're used to by now. I know it's like being one of a family of 8. You learn how to talk really, really fast if you're going to get any word in edgewise. And so I apologize for that. But Bob also knows he's got to talk over me if he's going to join in. So at any time, there'll be spots for you to participate. And one of them might be here where this is just data we picked off the web. This is not, don't write any of this down necessarily. This is private practice list of average salaries, median salaries in the industry. And really all we're doing here is setting the table because you have your own set of costs. Now, most of them are always going to be lower just because of the nature of who you are and the organization you work for, and more importantly, your limited revenue stream, right? So there's only so much you can pay the various people in there. But obviously you're paying them something, and it's going to include, these are your salaries. Also on top of this, you're going to have your fringes. And in my experience, this certainly was the case at where I was on the board. We had a pretty good package of fringe benefits. It was fairly high as a percentage, partly because we weren't able to pay them enough on the salary side. So it's kind of interesting. But that may be the situation you find yourself into. So those fringes and taxes and all the rest are a very important part of your compensation. Next slide, please. So when you do talk about provider costs, we talked about compensation in that last slide. There are other factors as well. And this is where we start to get a little more nuanced, right? There are productivity issues with your providers, which we'll talk about in more detail in the slide here, the next coming up slides. Then there's a whole list of non-clinical activities. How often are your providers around? How often are they able to see your patients or your clients, right? If they come in and you're on the 50-minute, you're an outpatient center and you're doing 50-minute visits and they see, they're available to see 6 or 7 a day, then their productivity is largely controlled by no-shows, right? People who don't show up and then they're twiddling their thumbs. Unless you've gotten aggressive on that and have some policies in place to deal with it, or you've opened your doors, which we tried for a while. We opened our doors to walk-ins, just and which is a horrible place to put somebody if, in fact, you don't have any no-shows. But we were getting desperate because we had a 30-35% very persistent no-show rate, and that was just killing us financially. So we have ways to increase that provider's productivity. Beyond that, we'll talk about those. The non-clinical activities, which you mentioned, and then the provider staffing mix. So that's, are there, people, if you do open your doors to walk-ins, perhaps there's a safety valve provider within your clinic. It may not be the provider that person's been seeing, but if nothing opens up, you have somebody that you kind of relieve the pressure with, have that person be seen by someone else in your practice. Down in the future, as a sneak peek here, we're talking about outcomes as a way to measure providers as well, and possibly compensate providers as well. Next slide, please, Chloe. Okay. This slide we're going to go through fairly quickly. There's a lot of stuff on there. I apologize. Some of these are fairly dense text-wise, and that's just to give you the information you need. Feel free to go back and look through all this. But and this may not apply to you. In the medical world, there's a little bit more focus on incenting and creating incentive-based payments for providers, right? To get what you want, you have to list those wants off. What do you want these people to be doing, which include, as you see down below, attendance and engagement, follow-up, productivity-related issues, and then reward them for that. And there's a lot of different ways to do that. A lot of ways are being tried that isn't as popular in the, or as common, maybe is the better way of saying it, in the behavioral health world as in the medical world. Next slide, please, Chloe. As you can see from this slide, so this is coming off some Medscape 2018. And it's a survey, and it only includes psychiatrists because they were talking about very high-level providers here. As you can see, many in the medical world are quite used to this by now. Some are probably expecting it. And these numbers are moving up radically and dramatically over time. If you went back 5 years, all these bars would be much shorter. But you'll notice at the very bottom is psychiatry at 8%. For reasons we talked about a little bit there. We do need, you do find that this industry is a little bit behind the curve when it comes to incentive payments. And on some level, you're probably fine with that. It's like, well, we don't really have any money to be paying extra to these folks anyway. But the idea being is that if you can tie their performance and tie the outcomes that they have a very big part in producing to enhanced reimbursements, then you're able to pay them more money. We, the shop I was, on the board of, we had the situation of, excuse me, we had the situation of being a union shop. You may have the same situation. And as a board, I kept saying, gee, we'd love to pay these people more. They're doing tremendous work. But actually, we weren't allowed under a union contract to offer any kind of bonus situation based on profitability, which was a head scratcher for me. I mean, it is what it is. That's fine. I understand to some extent why they negotiated those kind of things. But you may be under the same constraints. So that's just something to think about. You may need to put yourself in an environment where, first of all, you have the flexibility to pay people under an incentive system and then actually be able to craft one that gets you to where you want to go. Next slide, please, Chloe. Okay, so this is fairly straightforward. And it's based on the concept that you actually have a way of managing your productivity. If you're an outpatient, like I mentioned, if you're an outpatient 50-minute a person visit, kind of practice, you may not, I'm sorry, excuse me. You may not have this flexibility, right? They're either there or they're not. But in assuming that you do, let's say you're integrated with a medical care practice, and so you're seeing people that are being referred to you. You've got an office at the local FQHC or perhaps a primary care provider in your community, and you've got an office there, and the providers are now they've established a system where they have somebody walk in, and it turns out, their medical problems are related to their substance abuse issues or their depression. They have an ability to do as you probably have heard, the warm handoff to you in your office sitting there. And so those are more episodic, 15 minutes, 20 minutes. So productivity means more in that type of environment. Here, all we're doing is kind of showing you the power of what changes in productivity that occur. So we have these various salaried providers, And we've made an assessment of how many visits they see per FTE. And so what that cost is. And then we increase those visits by 15%. And what happens to those costs? And so what, it's pretty clear. If you could get those people seeing more and you're able to bill the same amount, then, and there's the key, obviously, then there's more money left in for incentives or other programs. So the math is pretty straightforward, and you're welcome to dive into that a little bit more, but it's not complicated. Next slide, please, Chloe. Okay. Provider cost per visit and client non-billable factors. So this, when we start to break down your providers, not as here's one FTE who costs you, $100,000 a year, so let's say, and ergo we always include that, total $100,000 divided by the number of hours that are in the day. That's at a very 30,000-foot level, if you will. What we have to start looking at is how long are those providers and all staff that you have actually available to work with your clients. And so that has all kinds of factors that work into it. The length of the work week, the number of clinic sessions, and whether they have other programmatic commitments. Perhaps you have a crisis outreach, crisis services center. We certainly did. It was a separate facility, so some of our providers would staff that at times. And when they're there, they're not obviously doing their usual outpatient activities. You've got clinical, there are members of clinical teams. They have travel time between sites. There's, of course, documentation, which is a massive piece of everything and not simplified necessarily by the advent of the electronic health record. And then, of course, they have CME ongoing. They may not even be in the office at a given time because they have CME obligations. And then the big one, of course, we chatted about it earlier, the no-show rate. Next slide, please. Okay, so there's going to be, throughout this rest of the presentation, you'll see this kind of slide has pretty much the same format. And we're not going to go through this in tremendous detail. But again, very simplistic on many levels. For that, I'll apologize, but it gives you a clear sense of how we're getting to where we're getting at this stage of the analysis, this kind of high-level stage. So we're assuming you have the 1.0 psychiatrist, psychologist, and a psychiatric nurse. Those are your main paid practitioners in your practice. And they have certain salaries. You have a 20% fringe percentage payroll that you're putting on top, and that's probably maybe a little bit low in your circumstance. Creates a total amount. You have how many billable visits. This is the way you've probably lived your life if you have a standard practice. It comes to $133.53 per outpatient visit for our Eastside Counseling Center that we've created here out of thin air. And then, of course, we look back and we say, all right, of those 4,700 billable visits, they involved only 940 patients. We made an assessment that they come in at 5. It's an assumption when they come in 5 times a year. You may have ones who you see monthly. That could be a large part of your practice. You could be some that you see only episodically. So, that number is going to change over time. But that's what we used here to drive to how many patients we had and a per patient cost. Okay, next slide. All right, so now we have the direct support costs. And right off the bat, we have to put in some caveats here. You'll look at this list, which is by no means complete. This is not to suggest that there aren't a whole lot more people that would fall into this bucket in a lot of positions. And you'll also, depending on how you allocate these folks, some of them may be in paid positions. I mean, you may be under a grant program or even a specialized medical program in which, your triage specialist or your qualified mental health professionals, some level below psychiatrists or therapists, are being compensated for their time, in which case they're effectively, in our model, a provider. But what we're saying here are folks who are contributing to the visit, may have some interaction with that patient during their treatment time, not in every single visit necessarily, just in the treatment plan for that given client. Do they see a case manager? Are they interacting with a care coordinator? Is there someone in your practice or someone you contract with who's a specialist in social determinants of health? And so they do housing, they do transportation, they do job recruiting. Maybe which stirred the other day about a credit union opening up in somebody's medical shop. Largely, to some extent, to probably just to rent the space and get the traffic flow. But if the two work together well, they could be teaching some financial skills. And we know how much stress, especially in this current COVID environment, losing your job is for folks. I mean, there's been a lot of evidence, you've probably seen it directly in your practice, that through this whole pandemic, depression and the incidences of mental illness have risen. The direct causality there is very clear. The pandemic, beyond your fear of your own health or those of your loved ones, your world's been turned upside down. So you now what was a fairly stable household with two incomes is now at one. Two incomes that became zero. You're on unemployment, and all the stresses that you can imagine. And you're the backstop for that. Your practice is the backstop. You're seeing the repercussions of that. So you may be having to interact with those folks in more ways than just your standard. This is a person who's displaying, you triage as being depressed or anxious. And so you've got a lot of tools, and some of those tools fit into the provider box, and some of them fit into this direct support cost. Next slide, please, Claude.
Dave, I would just say one thing about that.
Sure.
The overarching message there is that's just a list that we put together. The key is just to be anybody in your organization that has a hand in delivering that patient care that day. You want to make sure you have the ability to capture that person's time and get it into this bucket, because it becomes important to be looking at the overall cost down the road.
That's right. And there, you may have come up with creative titles and creative functionalities that we haven't even dreamed of here. Because as you know, there's a lot of different ways to characterize your services, and there's a lot of different ways. So group therapists would be in this area, and the folks who help those groups come together. Call center folks, even for that matter. Okay, next slide, please. Those call center folks will probably fall into overhead. Next. Okay, so here we are again. Bit of a random choice of who we decided to put in here with the salaries. I think the salaries are off the recruitment websites, so they're probably not too far off. But we ended up with now your case managers. You'll notice that there are two of them in this scenario, so they're not making $80,000 each in case you fell off your chair there with that. We'd love to pay them $80,000, but it's half that. Same with the mental health receptionist. So that reflects 2 FTEs and a 1 FTE triage specialist. So it's the same methodology as using before, same number of patients, and you can see that we're going to tack on to our total cost for our visits and patients the amounts you see indicated based on this math, which is pretty straightforward. Next slide, Chloe. Okay. We mentioned earlier this new term that we're introducing. Maybe it's not new to you. You may have heard this a million times, but in a lot of behavioral health practices, it's not a commonly used concept, enabling costs. But effectively, it's descriptive. And you can see the list here. Case management, again, if you've got a case, it could end up being an enabling cost. And there's no hard and fast rules to some of this. So if you were looking for that, we're probably going to disappoint you a little bit. The methodologies are very clear, and I think Bob would be the first to tell you again, this is your costs are your costs. There's ways to handle them. How you allocate them to various buckets is kind of up to you, though the key is to be consistent from period to period so that you're apples and apples. And we certainly do that when we're putting together cohorts of various similar organizations in order to create databases that you can compare against. It's extremely important that all the costs get put in there, as you can imagine, so that when we say that the average behavioral health organization spends X on fringe benefit percentage, that we've actually captured similar costs to what you are. So you can see the list here. This includes things like childcare program. You might have one at in the building perhaps that you contract with in order to see people on a drop-in basis, so that you don't have you eliminate that excuse. Oh, my kid's sick from home I had to stay home, and so I couldn't come to my appointment. I'm sure you tried every kind of way to make sure that your patients and your clients are able to show up for your sessions. Next slide, please. And again, here we go again, the same kind of calculation. It's all straightforward. Again, remember this first one we're talking about a very high level here. So, so you got some annual transportation costs. I ran into a center the other day who actually, this was in Ohio, I believe, where Medicaid was paying for Uber trips for their clients to get to their appointments. So that's pretty novel. I mean, you may not even have thought about that, whether that existed or not. But that's a door you need to knock on to see if it's possible. Taxis, Ubers, the bus, you know, you may be paying it now out of your own pocket just to get them there. You might not have to. It might be a billable service. Translation services are obviously key, and you know, there's almost no point. One that we could add in here would be, especially in the current environment, would be telehealth. Bob, at the sessions at the clinics that you were involved with, how did they, you know, how would you have handled telehealth as a service, the cost associated with that? Would that be overhead, or you know, was there anybody assigned to kind of keep the systems running? How did that work?
Yeah, because it was so new, we actually set it up as a separate cost center. We tracked all the visits, everything that happened in there, and we took all of the costs. We had to buy some equipment, and we had to do some training, and we had to do some wiring and some different things. But yeah, we did exactly that, Dave. We set it up as a separate cost center in both places I was working with, and I made sure we captured it. What we're going to do going forward probably is roll it more into the overall practice. It'll just be telehealth will be a kind of visit, a visit type, and there'll be a provider time that, but there won't be the same support staff cost. So you have to be looking at it in a different way of capturing total cost. But yeah, because it's so new, we decided we would look at it as its own separate entity.
Well, and that's fascinating because, as you know, there's two sides of that, right? There's setting the provider up in order to be able to have this telehealth transaction, if you will, this treatment time, and keep the appointment. On the flip side, you got your patient. Where is that patient? So Capital Link is also involved in another project in the Los Angeles area. We've been interviewing various behavioral health organizations over the last several weeks, and it's been fascinating. Some of them are finding that after an initial, you know, reluctance on the part of their patients and clients to involve themselves in this, have now actually adopted it. The people are really excited about it. But one of the ways of making this work great is actually buying headphones. So the privacy issue is huge. You know, you can imagine if you're home and you got your kids around, and you're, you know, normally this would be a very private transaction you'd be having with or interaction you'd be having with your therapist or your psychiatrist. Now you're home and the kids are running around, or your spouse is there. Instead you buy it as an enabling service, probably at a cost. They bought a bunch of headphones and they handed them out to their clients, and you know, this was a big hit. It allowed you some of that privacy piece that was missing. So everyone's getting creative in this new environment. So you can see this.
One of the things we did, we had that happen to us too. I mean, but what happened was some of the local community organizations got together and gave grants to small grants or small donations to us and to a few other healthcare providers to buy not just headsets, but in some cases laptops or iPads, because people didn't have them. So it's going to have to flesh out as you go, because if you're not careful, it could become very costly. But it's just so new that we have to kind of work our way through it.
And it is, and it's a process. We don't want to spend much more time on it, but obviously it's been a process. As you know, I don't know when you first got introduced to it, 5 or even 10 years ago, maybe this idea started to come up, and then, you know, they'd set aside a room with a TV and everything for this in some of the centers, but it was not really going. And all of a sudden, obviously, the virus has kickstarted it in a major way. So we're seeing evolution in an accelerated fashion in this particular type of practice. Next slide.
I think the other thing too, Dave, is that because of the pandemic, payers who were reluctant to reimburse providers for that service jumped on board really quickly and said, okay, we'll reimburse you for that service. Then at first it was just audio, then you had to have visual to get paid. Now they just do it for either or. So the payers really jumped on board too. The question is going to be, in my mind, in the coming months, as hopefully the pandemic trails on and we get back to whatever the new normal is, will the payers still embrace that philosophy? Because I think the patients are going to. I think the providers are going to. And I think as a guy, when you look at the support staff costs you won't have to have, and you just have a provider on his or her laptop with their patient at home, it's going to be a whole different world in terms of cost capturing.
Absolutely, and I, you know, if there's a bright side to this, and I don't know this, but you know, think about how the entire costing of that, what we still consider a visit, has changed, right? So now all of a sudden, if this is in fact the case, and your you know, your providers live in places where they have a little bit of privacy and they can close their door and have a nice looking, you know, backdrop behind them, or use one of the ones that these services provide. I mean, they could be, do you really need an office, right? Do you need to expand your offices if in fact this is what the future looks like? So again, we'll talk more about that in the next several presentations, because it's ongoing and it's evolving as we speak, and it's kind of exciting from that perspective to see this whole new methodology, treatment methodology, if you will, or modality, being, you know, evolving right in front of us. So I'm going to move on to this overhead costs, and everyone's familiar with kind of where overhead costs are. But you know, this is a list that I won't say is comprehensive by any means, but in a general sense should include everything: your admin and facility staff salaries and those fringe benefits. So their compensation writ large for the admin falls in this bucket. Your professional liability, and to the extent you might have malpractice insurance. You know, and that depends on your practice. If you deal a lot with you know, folks who are have suicidal thoughts or suicidal ideations, and you have to deal with those folks, you probably, on a regular basis, it makes sense to have a fairly robust malpractice insurance policy. So, you know, again, your costs that fit in this might vary, but you'll see them all in here. Next slide, please. And so how do you, with that, and they make up anywhere from 25 to 40% of your total costs. So you can't, and well, you can. I mean, we have traditionally, we've kind of lumped them all together, divided it by, you know, the number of patients or visits, and allocated those costs. Said, okay, all these people in admin deal with stuff that affects every visit. Ergo, you know, we should allocate costs that way. And I'd say, I mean, just there's an argument for that, right, Bob? I mean, it isn't irrational to do it that way, but it's not very targeted.
No, I think that it's the next slide, I think, talks a little about how to break that down a little finer to get a little, because what you want to do is try to get those costs as fine as possible. When you're looking at a cost of a site of a practice, and you're allocating overhead, you got a real good formula for doing that makes sense for that practice.
And there are elements to that. Even, you know, you'll notice some of the list we have down there are similar to what we talked about with providers, but there is such a thing as overhead or finance department productivity, for instance, right? Your billing and collections department. Can you create a metric that you probably already have that you know, measures how well they're doing their job by collection percentages, by number of phone calls they're making? Did you have any experience with that in your shops? Did you kind of set up those benchmarks for back office overhead folks?
Yes, we looked at our size as an organization, and then went out and looked at NAC standards and also MGMA standards, and said, okay, if you have an organization that's generating $60 million in revenue, you should have a finance staff of 9 people. You know, theoretically, you should have, if you're doing 270,000 visits a year, you should have a patient account staff of between 14 and 16 people, and so we used those metrics and we measured against that. We also measured against ourselves by setting some standards for the productivity and the amount of collections should do, how many charges a charge entry person should do in the course of a month. So we set individual productivity standards and overall productivity standards to help us justify the overall cost that we were allocating to the clinical sites.
And then, you know, the last one in this list here, outsourcing. And imagine you really need to have that level of understanding of costs before you can make the decision, should we really be outsourcing our billing, for instance, right? I mean, otherwise you're flying blind as far as you can just say, hey, look at all those people in the back office, and I don't see them on the phone often enough. We should just outsource this whole thing, right? I mean, that's kind of, on some level, that may be a decision manager makes, but it should be a little more thoughtful than that, and certainly math-driven, if you will, in making.
Yeah, should be. Outsourcing seems to be popular now in the patient accounts arena, And I have mixed emotions about it, but I think the measure there is you're not going to get rid of 14 bodies and save the payroll expense. Is what were those people doing? How quickly were they billing? What was the number of days from the time the patient was seen to the bill was sent out to you got paid? What was your denial rate? And what's your overall collection rate? That's what you outsource. Because when you outsource, you want to be able to measure, are they doing a better job than you could do yourself? And what's it costing you? And there was 6%, and the 6% was a lot more than if the staff had stayed. So you got to really know those metrics and know that calculation to get there.
Yeah, and real quickly, you and I have chatted about the value you've seen in just the transparency, right? When those people are in-house, you're able to walk in because of one particular bill that sticks out, and you can walk to that person's desk and say, what's going on with this?
Exactly.
You know, because it may be an avenue into a structural, procedural policy issue within the department that's only becoming clear through a certain billing. But when you send it outsourced, it's like a black box on some level, right? And that can be dangerous. So I'm not arguing against outsourcing, but
yeah, if the outsource company doesn't fully understand, like in Massachusetts, we have a lot of crazy things here. We have a health safety net and some other things that are different. If the outsourcing party doesn't understand that, they'll start just dropping stuff into write-offs and saying, we know what that is. We're just gonna drop it into write-offs.
There you go.
We started looking at it. We said, why were you writing it off? You got to go check because they had this other insurance. Well, we don't know how to do that. Well, that's why you should outsource it. So I think I think you can outsource it selectively, like parts of it, but you really got to have a good partner, I think.
There you go. Next slide, please, Chloe. I won't spend too much time on this but it's a fascinating, and because it's such a large percentage of your overall cost. I mean, if this was 5% or 10%, we'd have already spent too much time.
Yes, and before I do switch to the next slide, I just want to let you know, if anyone has a question, please feel free to type it in on the right-hand side. So that way, when we end with questions, I can be sure to ask that.
Thank you. But yeah, if overhead wasn't such a huge part of what we do, and a lot of it, because of the behavioral health world, so much of our revenue isn't even client. It's client driven, but it's not, the client isn't coming in with insurance necessarily, or self-pay, bringing their own money. A lot of it is grant and program revenue driven. That means it's just, you got all this grant management piece that is behind, needs to be done behind the scenes, if you will, to make sure you maintain those grants coming in and demonstrate that you're actually doing what you're going to do. Again, it falls, that oversight, it falls into your overhead. Here's a good, fairly the comprehensive list you were talking about, Bob. I don't know if you want to go through this real quickly about ways to allocate.
Yeah, I think what the message I think is here is that you're looking for the fairest way to allocate these costs. And where it says allocate by visits, these are the backroom operations that are there to support processing and handling all the work that relates to seeing a client or a patient that day. So health information systems, patient accounts, the billing, obviously. If you have a call center, a centralized call center, centralized referrals, site operations, site administration, their work is all driven by how many people come through the door. So we allocated that based on a visit basis. Looking at the other one, central admin, finance, human resources, they don't necessarily fluctuate based on how many people in the building. Well, then if someone comes in the building today or not, you still have a utility bill. Someone comes in the building today or not, you're still going to pay rent. So we looked at that as an allocation of what's the total finance department expenses as a percentage to the total company expenses, and that's how much we'll allocate across the board to the operating site. So finance is 10% of the total sites, then 10% of finance would go to the clinical sites. So we're just looking for a fair way for those. And then on the right-hand side, you do have in a building, you have different departments. So you have a residency department, so you have a specialty care department. We would then look at the square footage, we'd update it every year and say, okay, this department occupies this many square feet, which is 15% of the building. So we're going to give them 15% of the rent and the utilities and the maintenance for that part of the building. Again, and a means to fairly allocate all the costs that can't be directly charged. I mean, I'm an advocate that you charge as much directly as you can, but these things you just can't. So what's the best and fairest way to allocate it that everyone can understand? Because believe it or not, I internally in my career in health centers, I probably had to give a presentation on how I do allocations to our provider staff and to other staff probably twice a year, because I think it's very simple, but some people find it very confusing. All you're trying is to find a fair way to allocate those costs that can't be directly charged.
And the important thing here, and that's a really good point, Bob, is that if you're looking at this and going, wait a minute, how do I've got a bucket of overhead costs. How can I allocate some by visit, some by expense? Effectively, what you're saying here is that you're going to break down your overhead costs into 3 buckets. If you use this particular, all 3 of these systems, you'd have your visit allocated ones, you'd have your expense allocated ones, and you'd have your square footage allocated ones. So right off the top, what you'll see in an upcoming slide when we sum all these, instead of having 1 column for overhead, we'd have basically 3. And that way you are able to allocate it by different ways. Otherwise, it probably seems like, wait a minute, this is an apples and oranges thing. The other thing I'd bring up real quickly is, depending on your operating model, right? So if you go out with, if you're traveling a lot or going to conferences or something and you have meals, you charge those meals to, general overhead or your travel account, which would fall into these overhead allocations. But if you're a residential, let's say you're a residential substance abuse or substance misuse treatment facility, well, meals are part of your, you're providing meals to your clients because they're your guests effectively. They're there for however many days, weeks your system is set up to accommodate them. So that changes the nature of that. That's not really an overhead cost anymore. Now you're talking about probably what we call a direct support cost, Bob, wouldn't you? If it was
direct support staff or direct support or enabling costs, one or the other. But you can fall into either one of those. And I think that to today's point on the travel and meals, whatever, if you are working for a specific site and you travel and you capture those costs, I would still try to charge it to that site on the travel and expense. It would fall into support costs because it is part of support for those costs. But either way, I think the message for me is always, I don't get too hung up on where you put it, as long as you get it. You capture it and you get it.
Make sure you get all the costs included. That's exactly right. Okay, next slide, please, Chloe. We're going to try to move through here. We got about 8 minutes left before. All right, we're not going to spend a lot of time on here, but you are going to see a term. This is where the medical world and the behavioral health world kind of separate. And one of the places, obviously, there's lots, but one of them is in this use of the term ancillary costs. So these are lists that are from SAMHSA's directories of mental health treatment centers and substance abuse treatment centers. So these lists are thousands of pages long, and in there they quantify and qualify what every entity that they have listed does. And these are what they call ancillary costs. Well, in the medical world, if you said this ancillary cost to somebody in the primary care world, they generally think of lab and x-ray, which wouldn't show up in any of this unless it was down in primary care someplace. But this, and then you look at some of these and you're thinking, wait a minute, these are actually paid. I can get paid for this, so wouldn't I include this perhaps in programmatic costs and have within that program direct, indirect, overhead and enabling costs. So this is kind of the conundrum we find ourselves in the behavioral health world, is that there are so many ways to get there. There's so many treatment types and modalities that you got to be careful. If you try to say universally we should apply something across the board, that's not necessarily the case. So that's all this slide is trying to show. Next one, please. All right, so here's that one I was talking about. So we're just summing things up here. So the numbers themselves are kind of not really all that important. Other than that, you can see that there's providers, direct, enabling, overhead. You add them up, and in the end, you'd say your cost per patient, if you're on a managed care system, you'd take that $1,510 and you divide it by 12, and better hope that your PMPM, your per member per month payment, is at least that much, right? So even at this high level, you have some tools to you that you can take. If you've allocated costs, and Bob, you have many stories about going into payers in Massachusetts, armed with your folders and files to generate, to be able to back up these claims, so that when you say, look, you're going to pay us whatever, X, I need X plus $20 on a per member per month basis in order to make this work.
Yes, and a couple of times that we had people at Medicaid say, well, you can't show me that. No one's ever been able to show me that. So when we took out this analysis, we'd had this analysis in our detailed income statements. I was asked, well, how come everyone doesn't do that? And I said, I don't know. And Dave, you and I had a conversation with somebody, a payer. And I asked the question, how many times has a provider or a health center or a behavioral health organization came to you and presented detailed information to support their cost to set off some conversation about rates? And what was the answer, Dave? Remember?
Never.
So I think the message we're trying to get out here is that we, as the providers, have to take the wheel. You know, we can't let. First of all, we have to know our costs better than anybody else knows them, be able to support them, and we have to be driving the negotiation. We can't be sitting and say we're going to give you, you know, $50 PM, and you're looking at twice that for your patient. No, and here's the support to tell you why that's not sufficient. So we have to take control of that, and hopefully we're giving you some of the tools to do that.
Right. Next slide, please, Chloe. We're kind of getting near the end here, and we just have a few minutes left. So the problem with the math, if you will, in primary care versus behavioral health, and I know your behavioral health can fall into primary care, but let's just call it medical to behavioral health, is that, you know, there's a kind of a trade-off in the capitated system. Most of the value-based payment systems we're going to be talking about in future episodes are kind of presumption of being under a managed care program, a PMPM system. The problem with that is that the key to it is that you're going to have some number of your clients or your patients, however you want to look at it, who don't show up every month, right? Because that's in the medical world that they're not sick. They don't need to come in. They don't come in, but you still get paid. And you need that for those really intense patients who are in several times a week over a period of time, or are chronic and are in on a regular basis. But that modality may not work in behavioral health as well. To create stability, which is what the system wants in many of your patients and many of your clients, you need to see them often. You need to have them coming in monthly. You don't have the luxury of saying, "I want you to stay home for 6 months and we'll collect our PMPM," because that's not serving that person in the best evidence-based way. So it may be that we have to think about that. I'm only putting the slide out there for that consideration. Okay, next slide, please. So, you know, this is, again, to follow up on that a little bit, you know, how many times you see that patient is up to the care team. We can't be driven by the finance department, but that may be, you got to make sure that your way of interacting with your patients, getting to the outcomes, and we'll talk about outcomes in a future scenario session, achieving those outcomes, you know, how many times do you need to see them? And you got to make sure then that's the genesis of the fee-for-service system, was to pay you every time you saw them. That's okay. But if we're going to transition to managed care, then we got to make sure that, in fact, we've got, you know, what Bob, you've talked about many times, kind of a cushion, if you will, for the patients, for the folks whose lives you've been, you know, have been included in that group of people who you get paid for, but don't necessarily see all that often.
Yeah, next slide. And we look at it on the finance side. That's kind of how you balance the seesaw. You're going to have people going to come in 5 times a month because they need to, offset by someone who comes in once a year for their annual visit, or twice a year. So based on your patient panel counts and how many members you're assigned, and how healthy are your members? That's the other thing. And what are the conditions of your members? Yeah, that's the balancing act. Is the PMPM cover it all?
Thanks. Yep. Okay, next slide. We need to run through these last real quick. Okay, we're just going to move through these real quickly. Unfortunately, we also, you know, there's APMs, alternative payment mechanisms. The behavioral health world has not been very fast in picking these up. As you can see, in 2018, Medscape showed nobody in psychiatry was using an APM. Next slide, please. But in 2019, there were 2%. So, hey, great. And you'll see that 8% in the incentive-based payment systems that rose to 10% in 2019. So there is some progress. It's just very slow. Next slide, please. These next 2 slides I'm going to just refer to, and then I'm going to move on, because not many of you are probably running a pharmacy. You may be if you're big into medical assisted treatment. You may even be a 340B, though they're you know, discount drug program provider under Medicaid. It's a great program in the medical world. It's only slowly being picked up by certain behavioral health providers, so we're not going to spend a lot of time. But this methodology you could apply it to even other program costs. So you can walk through it. This one is based on scripts because it's another way of allocating, taking your overhead, figuring it all out. Next slide, please. And I apologize that we're moving through these fairly quickly, but you can easily go through them. It's very simple math. And it's just a way, if you have a program that is very incident specific or script specific, if you do have a pharmacy program, this is the way you'd want to establish those costs. Next slide, please. Okay, we're getting to the end now. It's sometimes, there's reasons we get the basics wrong. We're going to be talking in the next session about the detailed chart of accounts required in order to pick up the costs in a way that you can actually then make them actionable. You need to, utilize your EHR, your electronic health record, your practice management system that's built in to capture all the data, the denials and adjustments. And you got to make sure your HR systems are on reporting the kind of data you need as well. And then you're going to hear pushback from your staff sometimes that your systems are what they are, and we don't actually do this allocation because it's part of our mission to do this work, even though we lose money at it. I mean, there's all kinds of things you're going to hear. You have to stick with your guns and really apply this universally across all systems. Next slide, please. Okay, these are the last two slides on the conclusion. We are going to be talking about the fact that we're going to be moving on to an outcome-based, a value-based reimbursement system. We gave you these tools to kind of give everyone a base in how the fee-for-service and to some extent the managed care capitation environment works. Next page. So that's really where we're going to, is that you're entering into an environment in which the values and outcomes are being determined, and you're going to get paid for them. The key is who's defining those values and outcomes, right? A payer and a client might have two different ways of looking at what's an outcome that's I find valuable, and one of them is, well, you've reduced my cost, and the other is I'm feeling better and I'm more stable and I've kept my job and I have a stable family life. These are completely different, not necessarily contradictory, but they're different goals and outcomes, and we'll be talking about that. And when it's the payer who's driving the bus, we have to start talking in their way in their terms, and we have to start approaching them with ways in which we can demonstrate that we can lower their costs and make them happy and create outcomes that for your clients that are beneficial. Next slide. We're coming up to the end of this. So one part we're going to see going forward is that we're going to be focusing a little bit on that integration of primary care and medical care, because it's going to be hard to escape getting the costs, getting reimbursed based on medically identifiable metrics that already are set up in many systems to provide those shared savings programs. If you can achieve those goals, your job is to demonstrate that you played a role in that. Your interventions on the behavioral health side had a role to play in that. And that's very clear. And we'll have some examples up there in the next couple of sessions. We hope you join us. Next slide, please, as we kind of delve into how we go into that. So here's our last slide. Please join us on June 30 for preparing internal systems for gathering cost data. I apologize, we went a few minutes over. And if you have questions, feel free to respond. Bob and I are good about responding to every question that comes in. So electronically after this, we'll get to you directly. Be happy to engage with you if we can answer any questions that you might have. And here's the contact information. So thank you very much for joining us today, and we hope you'll join us going forward. Bob, as always, it's a pleasure chatting with you.
Thank you. It was a very, very nice session. Good fun. Hope we help people.
Good deal.
Thanks, Bob and Dave.
Everybody.
And as Dave mentioned, as of right now, we don't have any questions that I can ask, but if there's anything that you think about, feel free to ask any through the emails that we have here. We have both Bob and Dave's email and contact information. When you log out, you will be directed to a very brief survey, and any feedback is greatly appreciated. And thank you all for joining today, and I hope you have a great rest of your day.
Take care, everybody.
Thank you. Thanks.